To start a very interesting instruction course that is on 7 innovations that changed the world of ophthalmology. For that, I would like to request Padma Shri Professor Dr. J.S. Chittial sir to come on the dais. Dr. Jagdeep M. Kakadia sir, the doyen of innovation in ophthalmology, who has made the life simpler for all the ophthalmologists and saving crores of money for the ophthalmologists. I request him to come on the dais. Now I request Dr. Ramesh Shah sir to please come on the dais. Dr. Rajendra Prasad sir, the dynamic associate professor Dr. Parul Gupta from PGI Chandigarh to come on the dais. And Dr. Ankush. So we will start with Dr. Rajendra Prasad, and he will be speaking on complex, sticky and glued soft cataract management. IT people, can you help?
Good evening, and thank you, Professor Maurya, for giving me this opportunity to be here with all of you in this beautiful evening. So I'm going to talk about management of soft cataracts, because we all have been coming across all these soft cataracts more and more in our surgical practice. But the problem which lies with the soft cataract is the soft cataract is generally very soft, and it's glued to the capsular bag. And when you want to hold the nucleus or the complex, you are not able to hold, and the phaco probe cuts through. And if you do not get the hold, then you are not able to do any kind of separation or splitting of these soft nuclei. And you go ahead with the repeated attempt, and many times this repeated attempt may be very complex, and you may hit the posterior capsule. So we normally try to use the second instrument to bring the cataractous complex on the tip of the phaco probe. And this makes a lot of manipulation, and as you can see here, because there is a plate formation of the soft cataract complex, and this now bringing this plate out of the bag for the emulsification becomes very difficult. And sometimes what happens, like you try to hold this soft complex of the cataract. This is a total soft cataract, and when you try to hold, the phaco probe suddenly hits the posterior capsule. And once it hits the posterior capsule, we land up with the posterior capsular disruption. And many of these complications we come across with the soft cataract. So the best thing to do with the soft cataract is like you start with a good capsular axis, and that is a very, very important step. And the capsular axis in the soft cataract has to be done a little larger as we do in the hard cataract. So never make a very small axis, make a good large axis. And because if you have a large axis, then the hydro procedure and the rest of the steps are going to be very simple and without too much of manipulation. So this is how you get a good capsular axis. The capsule is generally very elastic in the soft cataract. And the second important step comes up is the hydro procedure. The hydro is very, very important in this soft cataract. You have to do a good cortical cleaving hydrodissection. Your fluid wave has to go through and through from one pole to another pole, separating the whole cortical complex out of the capsular bag. And this can be done with a good hydro needle, because this is important, because you have to have a flat hydro needle so that when you're injecting the fluid, it should spread. It should not go in a tunnel shape. It should spread, and then if you are able to spread the fluid wave, you'll get definitely a good complete hydrodissection. And the position of the tip of the hydro needle is another important point, because you don't just keep at the edge of the capsulotomy. Just go underneath the capsulotomy and go towards the equator. And if you are going a millimeter or 2 millimeters ahead of the capsulotomy edge, then only you'll get a good wave. So making a good fluid wave is very important in these soft cataract. Now, managing the nuclear complex or the cataractous complex, you have several techniques. We have been using many of these techniques in our surgical procedure. And it depends on how you feel that particular time, which technique is going to work in that particular situation has to be used. If you have a very soft cataract, pediatric cataract especially, because in these pediatric cataracts, the important points which I want to highlight here is because always stain the anterior capsule. And because, as I said, the capsular axis is very important, but you have to get a good capsular axis, because the capsule is generally very elastic. So your vector forces have to be very accurate, because many times you get into the problem of extension. So you just keep all the forces towards the center. Ultimately, you'll get a good large axis. And hydro procedure to separate the complex out of the capsular bag. And then you can just use a simple aspiration cannula, coaxial or bimanual, whichever is preferred. And you can completely remove the cataractous complex out of the bag. So once you complete this in these pediatric cataract, another important step which comes up is the PCC, which is very, very important to do if your child is less than 3 years or 4 years of age. And creating a PCC is not so difficult, because the capsule is quite elastic, and you can complete it with appropriate size of the PCC. And in a situation, if the child is less than 3 years, then you can go ahead with the partial anterior vitrectomy. So another important step. And then you can inject the IOL. Either you can go ahead into the capsular bag. If not, then you can just keep the IOL on the surface of the anterior capsule, and then slowly, like with the help of the dialer, you can just nudge these haptics into the capsular bag. And the last step, which is another important step, is the suturing, because always suture the wound, because the sclera is very elastic, because you do not get the hydration, a proper hydration. So put a suture so that you are secure and complete the surgery. If you have a little softer cataract which has a small amount of the brittleness in the complex, then what you can do is you can do this very simple technique called as a visco-flip technique. You just, with the help of the visco injection into the periphery around the equator of the cataractous complex, you can just completely flip out the whole cataractous complex out of the bag. And if you are able to do this, then the step to completely remove the cataractous complex becomes very easy, because you don't have to do too much of manipulation, no chopping, nothing. You just start aspiration, and we can simply complete this this way. Many times you come across with this acquired soft cataract. Acquired soft cataract have a little more gelatinous kind of structure, and it's more sticky. So in these cases, the best technique would be the stop and chop. But as you can see here, because the tip of the phaco probe has to be parallel to the surface of the cataract, because you do not go deeper. Just keep it superficially and do a small trench, and then with the help of the second instrument, you can complete the splitting of the nucleus. So this is how you can complete the splitting, and once you split the nucleus, then you can, because these heminuclei, they will automatically come on the phaco tip, and you can completely aspirate or emulsify the nuclear complex. So this is how you can complete, and even the epinucleus will come out easily, because if you are able to split it completely. Then you can take out the second segment, and similarly you can aspirate it. And if you come across the last and very important soft cataract, is the soft senile cataract. So this is the more complex kind of soft cataract, because the cataract, you have a good amount of the nucleus, you have a little brittleness in the nucleus, but the whole epinucleus and as well as the cortex, as the nucleus, they are all fused. So it becomes so difficult in these situations, and the important step which I am going to tell in these cases is to use a very low phaco power, try to hold the nuclear complex with the phaco probe, like as you can see here, and try to split the nucleus. This is how you can split the nucleus into two segments, because it's important, because these cases, like you have to try to split the nucleus, because if you are able to split it into two segments or into multiple segments, then these pieces, it becomes quite easy to bring out of the capsular bag, and we can complete the emulsification procedure. As you can see here, like I've made two segments. Now this is the four segments I'm trying to make, and then you can bring out these pieces very easily with the phaco probe and emulsifier. So this is how you complete the surgery, and then finally the important step in these cases is do a good capsular polishing, because many of these soft cataract, you will be having immature cells at the equator or on the posterior capsule. So capsular polishing of the anterior as well as posterior capsule is very, very important. Otherwise, you'll get the fibrotic changes later on. And if you do a good polishing, then you can put the IOL into the back, and this is how you can complete the surgery. So sometimes you come across with these complex soft cataract, and very common complex soft cataract we all have been looking into is the posterior polar cataract. The posterior polar cataract, 2-3 important points which we have to note it down. You don't rotate, you don't do the chopping technique. The best to do is make a small trench, stop and chop, and then split the nucleus into two. And without rotating, just dislodge these nuclear pieces out of the capsular bag and bring them on the phaco probe and start aspiration. Then use a bimanual technique to remove the rest of the cataractous complex, especially the epinuclei. As you can see here, the movements have to be very slow and safe. But this particular case had a pre-existing posterior capsular rupture. As you can see, a complete radial tear is there, a large radial tear from pole to pole. And before you take out your irrigation cannula, you just inject a good amount of the viscoelastic. And once we do this, we can put the single piece IOL into the bag. And how to put the single piece into the bag is just, again, simple technique. Try to inject the leading haptic into the bag, or you just keep it on the surface of the anterior capsule. And once you have done this, and then you can, with the help of the dialer, you can just nudge these haptics into the bag after injecting a good amount of the viscoelastic. And then, as you can see here, because I'm just trying to hold one of the haptic, bringing it towards the center and nudging into the capsular bag. So this is quite simple step, and the second haptic also can be nudged into the bag with a minimal rotation of the nucleus. And then finally, like you have this remaining cortical complex, which can be removed easily. And this is how you complete the surgery, because many of these cases where you have a pre-existing capsular tear, they do not have the vitreous prolapse. They do not get into the vitreous prolapse because the vitreous face is quite tough and stiff. So you may not have if you get a vitreous prolapse, then definitely you have to go ahead with the anterior vitrectomy. So thank you very much, and thank you, Dr. Moria, for giving this opportunity. Thank you.
Now I request Padma Shri Professor Dr. J.S. Tityal, sir, and he will be speaking on intraoperative OCT.
Thank you, Professor Arvind Moria, and good afternoon, good evening, ladies and gentlemen. Because we are discussing something which can change the thinking of individual surgeons, and you all understand OCT has been there for us, the anti-segment OCT, and that has given the dimension to look into a particular structure in three-dimensional view. Intraocular OCT is not an innovation. It is the application of one particular investigative tool inside the operation theater. We all started with the anti-segment OCT in your clinical setups. Then subsequently we had a handheld OCT because we thought that that can give you a new dimension in looking into your structures intraoperatively and doing things in a different manner. And this was the boon for us, the intraop-assisted surgeries, because this gives you an in vivo optical biopsy of a tissue. If you look into cornea, lens, and retina also, you can see the entire sections, you can see all the layers in 3 dimensions. In fact, this might change the diagnosis sometimes and also modify your surgical planning, and you can monitor these cases subsequently also. Just one example of incision like this type of picturization you can only see in OCT imagings, cannot be seen in a 2-dimensional microscope view. So these are advantages of having an intraop OCTs. Now I will take you through the various applications, the application wide of OCT. If you look into right from the ocular surface disorder to keratoplasty, cataract, retina, glaucoma, name anything, any surgical procedure can be highlighted, augmented by this investigative tool which has been now in application in the microscope. This is one of the review articles we have published in a survey, and people can go through this. This was our first publication related to intraop OCT, and this highlights the intraoperative assessment of ICL vault on the table, which normally you should know next day after you do the surgery, then you realize the vault is less or more. This you can see on the table now, and this vault can be measured also. This OCT doesn't have the micrometer caliber. So we designed the magnification factor. We could change with the C with the ruler also. And next day we compared the OCT picturization, it was matching. And this device where you can calculate the thickness of a tissue or a depth of a tissue in microns gives you a good assessment of all the structures also. Second application is in a keratoplasty. Name any keratoplasty, right from the PK to DSEC or lamellar keratoplasty. It has a huge role. And various studies have been done, pioneer study and subsequent discover study, where they found that the OCT really guided in decision making in more than 48% of the cases. Around 99% of the cases successfully they could acquire the desired image on the table also. This is one of my recordings of dark precision done. The partial thickness layer has been taken away, subsequent injection of bubble. This is a deep the descemet complex going backwards towards the iris, and after you do a stab, the bubble comes, the membrane comes towards the stroma, and you fill with the viscoelastic, goes down again. This is after dissection. So you can have beautiful orientation of surgery during the procedure. I think this has been a sea change innovation in how you see the structure on the table, and that makes things visible for you. This is the second study we have done for our DSEC procedures, which were published subsequently. We wanted to know how much time it takes for a DSEC lenticule to get attached to the stroma which we have created after descemet stripping in these cases. With the intracameral pressure and subsequent massaging from anterior side, which is the bimanual technique we use for a DSEC procedure, we realize in a normal cases, the graft gets attached within a minute. And you don't have to wait for 10, 12, 15 minutes to thinking that graft will get attached. And we should do initially stab incision with the anterior surface of the cornea and trying to release the fluid from there. That is not required with this procedure now. And understanding made us see better also. The graft is well oriented. If you have this sign, which labeled acute bevel sign, which tells you the graft is nicely oriented. This application also shifted to PDEC and DMEC procedures also to see if the graft is rightly oriented inside the anterior chamber. This is the correct orientation or DMEC roll. This is the incorrect orientation, and you could flip the DMEC roll to get into correct positions. This is what you see, the graft orientation. subsequently flatten that, then bubble, attach it anteriorly, and the entire surgery can be done effectively also. In fact, if you have a hazy media also, this gives you a possibility to see what is happening inside the anterior chamber, especially for DMEC surgeries also. Cataract related also, it gave us a lot of advantage. We were thinking that OCT has come for a retina surgery only. In fact, it has a much more application for anterior segment surgeries also. We could classify all the white cataract we saw through the microscope pictures and grade them in difficulty-wise also. To grade type 1, type 2, depending on the lamellae, hydrated cord fibers, and the pockets inside them could be visualized in anterior segment OCT, and you could subsequently see this is type 2, which is a most risky case where extension can happen because these hydrated fibers doesn't allow the fluid pockets to release once you do a capsulotomy like this. And this can be a challenging situation also. In fact, this video of ours was given the Best of So award in American Academy in 2019. You saw this is the hill or a mountain coming up with these fibers, not letting this pressure go down. And you had to put a dispersive viscoelastic over that to flatten and subsequently make a small opening. Take out the entire hydrated cortical fibers by aspiration with the bimanual cannula, and entire convexity gets into concavity, and you can do a nice rexis subsequently also. This OCT pixelation gives us the idea which are those cases where you can do needle aspiration, you can do a puncture, you can do a aspiration, can be classified them also. Similarly, posterior polar cataract, you saw a nice video from Dr. Rajendra Prasad. You can categorize the morphology of difficult cases by seeing the posterior pole. If the PC is clearly seen, this is type 1 where you can do normal surgery. If PC is not visible in the central area, difficult cases, or there's a moth-eaten appearance or a conical shape, ectatic shape, these are very difficult cases of posterior polar cataract. And surgery, cataract surgery, we could give it to the people seeing us, like our students, they could visualize what is happening. You do a delineation, you hardly see there. Like you can see in a 3D appearance, there's a fluid space between the endonucleus and the epinuclear cushion. And this is the advantage of having a 3D image of a case. And you can see I'll do a hydrodissection now. You'll see a multiple space coming there. And that tells you have a delineation here and you have a dissection here. And that's how the surgery becomes faster and effective in these cases also. During nucleotomy also, you can see how deep you are chopping also, how deep is your initial trenches in these cases. Now after the end of surgery, you know the epicortical cushion is still there and PC is intact. And in fact, this gives a very nice view. IOL centration also, tilt can also be appreciated. This is what you see, the IOL nicely placed, and the relationship with the PC can also be judged. You can tuck the lens little below to have more attachment towards the PC also. So these things can be seen if you have a OCT pictures on the table also. The wound configuration, the wound related damage can also be assessed very, very clearly in these patients also. So in cornea-based surgeries, in refractive surgery where there can also be application now. The newer generation devices, they all have attachment OCT. If you look into a silk surgery, the entire surgery is done under OCT guidance now. So this is what we have done in our patient SMILE. You could see where exactly your dissection is happening, anterior to the lenticule or posterior to lenticule. Any lenticular adhesion can be seen also. This is the final video of mine where you can see what happens in the wound area. This is a Fuchs patient. I'm doing phaco here, the completion of phaco. And towards the end, I was thinking everything's complete now. I'm doing a hydration of the wound area. I could see some flare here and little anterior haze coming up. To open the OCT, and I could see in the OCT, entire descent had detached up to here. And I shifted my cursor towards the cornea, and you could realize there's a large area of descent membrane detachment. This could have been missed if you didn't have the OCT picture with you, and next day, entire cornea could be white. And this could be managed effectively by injection of air on the same sitting and managed. So that is the advantage of OCT pixelization of all sorts of anterior segment surgeries. I would say the application there, right from the keratoplasty to refractive surgery to pediatric cases. In fact, in pediatric cases, we had much more advantage because these kids don't allow you to do a good examination. Under the general anesthesia, you can see all the structures very, very clearly and define your diagnosis and do a good surgery in these patients also. The futuristic point of view, OCT attachment may be mandatory for all the microscopes in future. And if you have a device like RTO digital microscope, you can see in a one screen everything in a large image. That makes things more and more visible also. Thank you for kind listening, and this is a book you can have now, a simplified IOL power calculation in your hands, hardly 150 pages, everything compiled in a very nice manner. Today is going to be released in AIOS, and you can have a book from JP. Thank you very much, sir.
Thank you very much, Professor Tijal, for the wonderful presentation of OCT, intraoperative OCT uses. And now I'll request Dr. Arvind Moria to give his talk on a novel progressive polyfocal IOL to correct all types of the vision.
And thank you, AIOS, for giving us the opportunity for this wonderful instruction course. So I will be speaking on a new and novel progressive polyfocal intraocular lens that is a non-negative dysphotopsia, glare, and halos intraocular lens. So what you require of an ideal premium IOL, so it needs to correct all types of vision, no negative dysphotopsia, no glare or halos. It needs to be pupillary independent and no effect of angle kappa and alpha, and also it needs to be cost effective also. So we are doing a world's first clinical trial. So to prove any hypothesis, we need to do clinical trials, and the best one are the phase 4 post-marketing clinical trials to observe changes in the uncorrected distance, intermediate and near vision, contrast sensitivity, depth of focus, reading speed in a sample size of 278 cataract patients undergoing bilateral phacoemulsification procedure, single surgeon at an institute of national importance, and inclusion criteria 20 to 70 year, clear cornea, healthy macula, up to NS4 and minimum 1 month follow-up. So till now we have operated 47 patients and 94 eyes, 25 male, 22 female. So the best corrected pre-op to uncorrected distance and best corrected visual acuity in logMAR. So it increased from 0.5 average to 0.0 in 48 patients. 24 they had 0.1, that is 6 by 7.5 logMAR, and in 22 eyes it was 6 by 9. When we compare the post-op intermediate uncorrected vision, the computer laptop font size of 8 equivalent to intermediate 6. So in 90 eyes it was intermediate 6, in 4 eyes it was intermediate 8. And as we compared the post-op uncorrected near visual acuity using the Jaggers chart, so in the 90 eyes it was N6, in 4 eyes it was N8. So as we compared the contrast sensitivity as this study, so it has a fairly good this contrast sensitivity as compared to the other IOLs. Now coming to the depth of focus, it has an excellent depth of focus. I have never seen in any premium IOLs. It has an excellent depth of focus from plus 1.5 diopter to minus 3 point diopter. So the vision remains 6 by 6, 6 by part, or 6 by 9 between this range. I have never seen such a IOL. So we compared, this is one of the patient, you can see excellent depth of focus in a patient, Srimati Nanu Devi. I have taken the consent from her to show this image. So as we compare the other premium IOL, so it has the best depth of focus. As we compared this study, they have compared these 80 Lisa, iCryl CERT trifocal versus extended depth of focus intraocular lens, iHands. So as you can see in this diagram, so we have the best depth of focus in this intraocular lens. This study was published in Indian Journal of Ophthalmology. Now coming to the reading speed, so it has excellent reading speed of more than 200 words per minute. So in the 47 patients Autofocus Pro implanted, the patient satisfaction is 29 are extremely satisfied, 15 very satisfied, and 3 are satisfied. And not a single patient are complaining of negative dysphotopsia. And one patient just recently in our OPD has compared of glare, otherwise not a problem in other patients. So how it is different from the other IOL? So you can see in the first picture, it has a large optic size of 7.5 millimeter, and the overall size is 13 millimeter. So it covers, when we compare it in the lower picture, so there is no gap, there is no temporal gap. So there is no aphakic area of 10 to 20 degree that is causing negative dysphotopsia because of the large optic size. And now coming to the L-shaped, this, you can see the haptic. So the 6 millimeter arc length contact area at the capsular back fornix. But we can compare the other premium IOL, only the loop tip is in contact at the capsular back fornix. So it gives a rock solid rotational stability. And there are 2 holes, so they needs to be superiorly placed. And how it works, what is the principle behind giving all types of good vision without negating the angle kappa and alpha, is because of the GRIN technology, that is gradient refractive index technology. So in the upper part it is 1.42, and when we come down it becomes 1.52. So in this way it is able to provide the best vision, the distant, intermediate, as well as the near correction. So when we compare the data from the systematic meta-analysis, these are the highest order of evidences and the Cochrane review articles with results of our data. Autofocus Pro is the best unique ponyfocal progressive and only ringless posterior chamber intraocular lens correcting distance, intermediate and near vision with no negative dysphotopsia and very less halos or glare. So this was the systemic meta-analysis. We compared our data with this study. My acknowledgement to Dr. Jagdeep M. Kakadia sir for this wonderful innovation. This IOL is now available in preloaded fully hydrophobic form also, and very soon toric version will also come. Yeah, that's what I'm telling. Hydrophobic version is available, preloaded, and toric version is also about to come. Thank you so very much.
Thank you very much, Dr. Moria, for the...
Any comments, sir? Kakadia sir, if I missed anything? What is the origin of this? Who gave you the inspiration? I think
the inspiration is right here, Dr. Ila, my better half. And actually, when she became presbyopic, she didn't want to wear the near vision glasses. So she started using Bausch & Lomb multifocal contact lenses, which if we have seen on slit lamp, we know that it's ringless, and yet it gives an excellent DI and distance, intermediate and near vision. So she said that if Bausch & Lomb can come out with a contact lens like this, why can't they come out with an IOL like this? So me, RC and Ila, we went to Bausch & Lomb's headquarters in USA, and we said to them that you have Envista material already and you have the technology, why can't you make? So they said, they bugga us that it's impossible because there's air in front of contact lens and there's aqueous behind. Whereas in case of IOL, there's aqueous in front and vitreous behind, which have more or less the same refractive index. So air versus aqueous is 1 versus 1.336. So they said it's impossible. But she was after me that no, it should be possible. You have to find a material which will have a similar difference of index of material, index of refraction. So we started the journey. We talked to Contamak, and Contamak provided, they made a special button for us, and Lifeline made the IOLs for us. And the journey started somewhere in 2016. We finished the product by 2019, and it's already 5 years, and more than 40,000 IOLs have been implanted by more than 150 surgeons.
Congratulations, sir.
Thank you, sir.
For giving us this wonderful innovation, sir. It's amazing.
Thank you, sir.
So and also cost effective.
All thanks
and,
to her.
Thank you so very much, Dr. Ila Kakadia, ma'am.
Thank you.
Thank you very much, Dr. Moria, for the wonderful presentation. And our next talk is by Dr. Jagdeep. Dr. Jagdeep is going to talk on OmniGlow, the stereo coaxial illumination device.
Audio visual, please. This is a voice talk, so you have to give the volume. Hello, dear friends and colleagues. Today we are very happy to introduce to you OmniGlow, which is a stereo coaxial illumination device having its own dual lights which can be fitted at the bottom of any surgical microscope, which will convert it into a Lumira eye-like stereo coaxial illumination. It is quick and easy to attach and detach OmniGlow, and when fixed with a single bolt, it becomes integral part of the microscope. And OmniGlow is now complemented with VideoGlow, which is just a 50 grams matchbox size micro-head full HD video camera which is inserted directly into the beam splitter without any C mount or L mount or DSLR mount. It can record videos and photos in laptop and or desktop, and also can simultaneously live stream to multiple monitors inside the OT as well as outside the OT in conference or waiting room. It can also do live streaming on YouTube. With OmniGlow, omnipresent, homogeneous and uniform and full red reflex with greatly enhanced stereopsis is 100% guaranteed in any position or any tilt of the eyeball. With OmniGlow, we never need blue dye for capsulorhexis except for white mature cataracts. Not only we can see, but we can also record with VideoGlow what the surgeon sees in exact and in vivid and beautiful colors. In hydro procedures, fluid wave and golden ring reflex can be recorded so well. Red glow is omnipresent even during the phaco-fragmentation procedures. OmniGlow also has enhanced stereopsis optics. Please notice that even in this 2D video, we can fairly well perceive the depth, the enhanced third dimension. Thanks to the optical phase contrast of OmniGlow, we can visualize every optical interface so well that surgery becomes a real pleasure. OmniGlow not only enhances glow, depth and contrast, it also enhances surgeons' confidence and morale to handle tough cases. Please notice the amazing clarity of interface between the BSS and Visco. Also the clarity of diamond dusted tip of the aspiration handpiece. The beautiful view of cortical sheets, cortical fibers and posterior cortical fibrils. With OmniGlow, we can see the anterior and mid-cavity vitreous so well. Even in 2D video, we can perceive the enhanced depth. Removal of cortical fibrils from the fornix as well as from the posterior capsule during the vacuum polishing of the PC as well as the star folds of the PC are all so well visible. Polishing of the anterior capsular rim is not only beautifully visible but also so well recordable with OmniGlow and VideoGlow camera. OmniGlow ensures full red glow even in small pupil, in any tilt of eyeball, in any position. OmniGlow name is derived from the fact that it gives omnipresent red glow which the conventional illumination of normal or basic microscopes cannot give. Even through a 2 mm pupil, glow is sincerely and faithfully always there with us in any tilt or any position of eyeball. Even in a nearly mature full cataract, we can still see some glow with OmniGlow. Shift the focus 15 mm down and we can see on screen the posterior pole, disc and macula on table without any additional optics or lenses. Thanks to the superb glow, excellent contrast and enhanced stereopsis, all due to the phase contrast stereocoaxial optics of OmniGlow, we can do Rexis modification or enlargement for matching the Rexis border to the IOL's border so easily and so confidently. Thus, OmniGlow gives us the additional power, proficiency and finesse of doing femtolaser-like accurately sized and well-centered re-CCC. Visco wash is not only clearly visible, it is so beautifully recordable, washing out debris in front as well as from behind the IOL. The combination of OmniGlow and VideoGlow gives nice smileys, not only on patient's eyes and face, but also on surgeon's and entire staff's face. Not only intraocular surgeries, even extraocular and adnexal surgeries are also so well recorded. We can beautifully see the opened ends of the Schlemm's canal and an aqueous vein with aqueous oozing. See the clarity of the scleral and the episcleral veins also. VideoGlow RC is the retinal version of our camera for excellent recordings of retinal surgery. This is ERM peeling surgery with brilliant blue dye staining of the ERM patches. With VideoGlow installed on YAG laser, both of which by default are having top class optics, this can become our ultimate photo and video slit lamp. This is YAG laser clearing of milky PCO recorded on VideoGlow camera attached to slit lamp. His camera has a nice Dolby mic so it can record sounds and commentary, and the commentary can be recorded if the surgeon wants. The mic can be turned off if the surgeon does not want to record voices. Recording YAG iridotomy with VideoGlow camera mounted on slit lamp. We can see the fluid aqueous gush once the iris is perforated. OmniGlow is like a sunrise in eyes. The Space Tech, ISRO or NASA level optics of OmniGlow and VideoGlow allows us to see and record the capillary blood flow the RBC clumps and plasma flowing in corneal venous vessels. Thank you very much for your kind attention. Thank you, Dr. Moria, sir, for this great opportunity to be participant in this session. Thank you.
Thank you very much, the wonderful device you have invented. Now, what is the availability of this device like, and what is the cost?
Sir, availability now is from Orolab.
Orolab is-
So either you can contact me or Orolab.
Okay.
And I would also suggest that you need a video glow camera as well, because your surgeries are excellent, but recordings are not 4K. So I'll be definitely happy to have you a camera of video glow. Regarding the cost, the Orolab will tell you the cost.
Okay, all right, all right.
Or I can do it.
But it
personally
must
too.
be much reasonable than these other
It's
cameras.
much reasonable. It's at
1/10, okay,
yeah,
that's good.
At 1/20th actually. At 1/20th of the cost, it can convert our existing microscope into a Lumira 700.
Right. Thank you very much. Thank you.
Right, sir,
Thank you
thank
so
you.
much. And now we have the next talk is by Dr. Ramesh C. Shah. And you all know Dr. Ramesh is also one of the very great innovator. And he's going to talk on TraboClean, ab externo non-invasive ultrasonic cleaner of trabecular meshwork.
To give me the opportunity to participate in this session of innovation. This is our great innovation where we treat the open-angle glaucoma and the pseudophakic glaucoma.
It's a voice video, so please what?
It is therapeutic ultrasound for glaucoma, for saving sight with sound. We have financial interest in TraboClean. EUG is originally the concept of Dr. Donald Schwartz, who is a senior prolific cataract surgeon in Long Beach, California, in the USA. And we have a lucky opportunity to work with Dr. Donald Schwartz in the last 12 years. It is a well-known and well-documented fact that ultrasound phacoemulsification lowers the intraocular pressure. We also know that harder and bigger the cataract, more is the IOP lowering effect. Is it only due to deepening of the anterior chamber and widening of AC angle? Then why not this happens in cases of sutured ECC or SICS? So Dr. Donald thought it was probably due to ultrasound energy. Spray of the stray ultrasonic energy is actually cleaning the trabecular meshwork by ab interno approach because of the sonomechanical vibrations. While giving 30-watt energy at phaco tip, we are unknowingly also giving 3-watt energy to opposite one quadrant of trabecular meshwork. Ultrasound is also known to trigger a cytokine cascade, which ultimately leads to a significant reduction in intraocular pressure. Cytokine cascade effect induced by ultrasound is exactly same as that induced by slit lamp laser trabeculoplasty. So we thought that if ab interno ultrasound in OT can lower intraocular pressure, can we achieve it by non-invasive ab externo approach in OPD or as an office procedure? So we designed a handpiece and a console to deliver low intensity focused ultrasound of 3-watt power of 40 kilohertz frequency to the trabecular meshwork as well as to the canal of Schlemm by an ab externo non-invasive approach. This is how the current working prototype looks like, which weighs less than 2 kilos. There is a console, there is a foot switch, and there is a handpiece. After confirming the safety of repeated procedure in rabbit model in vivo animal studies, we started humanized in vivo studies. TraboClean is as good as cleaning a blocked tea strainer by sonomechanical vibrations as well as by induction of cytokine cascade, which is analogous to SLT. In fact, SLT only has cytokine pathway, whereas TraboClean has sonic vibration pathway as well. In this video, we can see the mild but focused ultrasonic vibrations of the probe tip, which are so gentle and so benign that we can actually stop them by forcefully grasping the tip, which cannot be done with a phaco tip, which has a 10 to 12 times higher ultrasonic power. The trabocline TUG treatment is non-invasive OPD or office procedure which can be easily performed under topical anesthesia. After insertion of the speculum, the eye is marked at 4 cardinal points around the limbus. 2% lignocaine gel will work as anesthetic as well as ultrasound contact gel for better transmission of the sonic energy. Limbal spot treatments are to be given for 60 seconds at each clock hour position. We can give 4 spots, 8 spots, 12 spots, or 24 spots. 1 spot of treatment approx gives us 3 mm IOP reduction. 5 to 15 minutes is the total duration of TUG treatment, and this medication-free IOP reduction and control will last for approx 6 to 8 months. This is the comparison of number of spots versus pharmacological equivalence of their IOP lowering effect. These are electron micrographs of treated versus untreated areas of trabecular meshwork. In last 13 years, over 900 patients are treated with over 12,000 post-treatment examinations. 50% fall of IOP is measurable in 6 hours after the TUG treatment. In 24 hours, IOP is fully down as per the number of spots. Trabecular meshwork cleansing effect lasts for 6 to 8 months in more than 94% of cases. We give repeat TUG treatment every 6 to 8 months, and it can be repeated as many times as needed for the lifetime of the patient. When we treat the second eye, the first treated eye shows approx 25% further reduction of IOP. So treating 2 eyes separately at an interval of 7 days is more beneficial. This is due to cytokines going to other eye through blood circulation. The dictum is treat the worst eye first. For naive POAG patients, we treat directly. For patients on topical drugs, if we know their virgin IOP max, we treat TUG by n number of spots and stop all medications from that day onwards. For those patients who are on medications in whom we don't know what is their max IOP, then we stop all medications, allow a washout period, measure IOP max, and then treat with TUG for n number of spots accordingly. Best and longer lasting TUG results are found in pseudophakic patients. Very mild discomfort without any pain, just for 1 day, is the only post-op symptom. Mild redness and very, very mild aqueous flare just for 1 day are only post-op signs. Topical or systemic, NSAID or steroids are not to be given because we do not want to suppress the cytokine cascade. They are not even needed. Compared to SLT, trabocline gives 20% more IOP reduction. This is the publication about trabocline TUG. Ultrasound stimulation on uveal tissue is known to induce long-term secretion of mTOR. mTOR is an enzyme fully named as mammalian target of rapamycin. mTOR is known to induce the regeneration of optic nerve and spinal cord. Activated mTOR induces and enhances retinal ganglion cell regeneration and rejuvenation. We can drive neural regeneration through mTOR cascade. Trabocline TUG activates mTOR pathway, which leads to retinal ganglion cell regeneration, which not only holds the progression but actually reverses the glaucoma and the field changes. After 2 TUG treatments in 1 year, the RNFL thickness is increased from 0.099 to 0.202. This is another case in which in 13 months after 2 TUG treatment, the RNFL thickness has increased from 0.021 to 0.160. As the RNFL thickness increases, cuffs get filled, so the CD ratio decreases from 0.79 to 0.57 in this case. In visual fields also, we can document and see these changes. In this case, mean deviation has improved from minus 1.83 to minus 0.91 in 17 months after 3 TUG treatment. In the left eye of the same patient, mean deviation has improved from minus 3.96 to plus 0.04 in 17 months after 3 TUG treatment. Trabocline is the revolutionary and the only treatment which can reverse the glaucomatous damage. Trabocline TUG is a double-armed sonic sister of the single-armed slit-lamp laser trabeculoplasty, which is easier, portable, there is no learning curve, and is a lot cheaper than the SLT. Thank you very much for your patient listening.
Thank you so much. Such a wonderful device you have invented. And since how long it's been in practical use now?
In both of our clinics, I think about 4.5 years.
4.5 years.
4.5 years.
Okay, that's very good.
And the thought about increasing the field was given by one of the patients only. He had a very small field before the treatment, and when I did it for the first time, he said that I can see the things from side better.
Okay.
That was the first time we actually thinking and started documenting and he had a significant improvement in the field of vision, plus that has been maintained for last 1.5 years.
Okay.
And he's my neighbor only.
That's good. So how many sittings he needed to do that?
Hanji?
How many sittings were done for him?
We have done 2 sittings so far because it's only 1 year and 2 months, 3 months.
Okay.
We 7 to 15 days we wait for the other eye. That glaucoma drop is continued till we do, because we don't want anybody to lose the sight. Even
Definitely
if our treatment are not effective.
Treatment for the other eye, that is obvious. Yeah.
But the most important, biggest advantage is redness, the excoriation of skin, everything disappears very significantly. I had one patient which has come from Valkeshwar, which is supposed to be the distant times. It is almost 45 kilometers. She's one-eyed patient. Somebody has told her and she came to us and she was so bad that she was not able to move out of the house because of the drops. 3 drops she was putting it and she was one-eyed. So we did the TUG and we said that you have to follow up regularly. She is off medication for last 2 years. With 2 or 3 sittings of TUG has been done. She slightly improved the quality, the field of vision, but she is symptom-free and she is so happy. For the first time, she said, after so many years, I am going wherever I want to go, independently. Yeah. 7 days you can wait or 15 days, because we want to know whether the effect of this or what procedure has been effective or not. There is nothing standard protocol for that, but we want to be sure that the first eye effect is then we proceed to the other eye. Why we don't do together? Because we have a small advantage of doing the other eye after some time. So there is some amount of reduction in the opposite side also, which is treated before.
So when what we noticed was that when we treat the second eye, we get 15 to 20% additional hypotony on the first treated eye. So instead of treating both eyes together, we then started treating at a 5 or 7 days or 10 days interval. That is because of the cytokine advantage, which is induced additionally by the second treatment in the second eye.
See, today the mission for both of us is we don't want a single patient to lose from glaucoma either the field of vision or the quantity of the vision. That is the new missions which both of us have taken. So we have 3-4 things which is there with the glaucoma. One of them was Trabocline, other is that OmniFlow. And
OmniFlow is going to be presented next by Dr. Ankush Mahajan.
And something probably might come in about 6 months' time. So we don't want first the drug-free, the local drops-free, and the second one is that nobody should lose the vision. And probably we might get, if everything goes well, something might happen in USA, and we might get the approval from USA.
Right. What is the frequency, the maximum frequency you use in this
It is
machine?
40 only, 40
40,
hertz.
40,000. Okay. So that is fixed or you can change it?
No, the intensity can be, I don't think we can change the frequency.
Okay.
Intensity
So
might,
the reason for 40 kilohertz selection is that it is the phacoemulsification frequency, and it is time tested and safe for the eye and for the uveal tissue. That's why we selected the same. And the effect of hypotony induced by this kilohertz is already well reported, well documented in the previous literature. That's why we selected.
So any side effect, like when you are using 40,000 frequency, could there be a heat generation in the trabecular meshwork? Or
No. The wattage is so small, it's a very, very small watt. You can hold actually. You cannot hold the phaco needle in hand. Your flesh will burn with phaco needle holding. But this probe, we can stop from vibrating just by holding it in hand. It's very benign. It's very benign.
and it is designed in such a way that it increases the temperature up to 41 degrees, not more than that. So patient hardly feels that.
Right. So I think this very, very important device
Thank you so much.
like this should have been presented in the mainstream sessions, and because bringing it to the last session not justified. And what I feel is like we in Delhi Ophthalmological Society, we have 2 sessions on the near innovations, which is going to be in the mainstream. And I'm preparing these 2 sessions. So I would like to have this session, this talk also in that session. So you can send me the topic. I'll put in that the innovation session, which is going to be seen by almost 2,000 people. So I think that should be, because at least, because see, these are the, what I feel is like there are so many innovations coming from the West, but we Indians are all doing very, very great work. And at a very minimal cost, that is more important, because we need something like which is reasonable, which is accessible, and works well. So I think these devices, what you have done, especially the camera and this particular machine, I think this should be publicized in a greater way, and people should know like what exactly these means to them. So I think definitely I'll invite you to send me the topics. I'll put in the innovation session. All right. Thank you very much. Thank you
so much.
Thank you so much. And we'll go ahead with the next talk by Dr. Parul Chawla. Dr. Parul is at Chandigarh. She's in the PGI professor over there. And she's going to talk on Porbedo nomogram prediction of probability of rubella based on eye outcomes.
Thank you, sir, for the opportunity, and I thank Professor Maurya also. Today I'll be discussing about this nomogram that we've developed. We have named it the Porbio nomogram. This is the prediction of probability of rubella based on eye outcomes. So rubella is an important infectious vaccine-preventable etiology of congenital defects with disabling and life-threatening manifestations like miscarriage, congenital birth defects, and stillbirths. Rubella vaccination administered to the pregnant woman preconceptually helps almost 100% prevention of transmission from mother to the fetus. Lack of initiation of this vaccination in many developing countries makes it one of the leading causes of blindness and deafness, with an estimated incidence of 1 lakh children being born with congenital rubella syndrome or the CRS in a year. CRS comprises of sensorineural hearing loss, brain damage, heart malformations, and ophthalmic features like cataract, glaucoma, retinopathy, microphthalmos, and microcornea. At the level of primary and secondary healthcare centers, where larger populations are routinely catered to, it is plausible that the rubella cases could be overlooked and hence the treatment not initiated. Though evaluation of ENT signs and heart malformations requires a trained physician, and assessment of ocular signs is relatively easy, and signs like cataract, which is seen as a white reflex, microphthalmos is seen as a small eye, microcornea is seen as a small cornea, and they could be easily seen by an ASHA worker, even using a torchlight. Hence, we plan to develop a prediction nomogram based on the data acquired from multi-center surveillance sites to assess the probability of an infant being at risk for congenital rubella based on demographics and ophthalmological findings. So the aim of the study was to develop a prediction nomogram to assess the probability of an infant being at risk for congenital rubella based on demographics and ophthalmological findings. This was a cross-sectional sentinel surveillance study conducted at 5 centers spanning pan-India between November 2016 to December 2019 and involved 1,134 infants. The diagnosis of rubella was made using standard guidelines given by WHO, and for construction of the prediction model, laboratory confirmed cases were grouped as at-risk infants and the discarded cases were not at-risk infants. What was suspected CRS? That is suspected congenital rubella syndrome. Any of the following in an infant, whether there was a structural heart defect or hearing impairment or eye signs or maternal history of rubella and a strong clinical suspicion. So this was suspected CRS. What were the clinically confirmed CRS? At least 2 clinical signs in group A and 1 sign in group B. What was group A? Group A constitutes the ophthalmological signs, heart disease and hearing impairment. And group B is microcephaly, delay in development, splenomegaly, purpura, radiolucent bone disease, meningoencephalitis, and jaundice within 24 hours of birth. What is a clinical compatible case? Signs and symptoms of CRS, but a blood sample could not be obtained. Laboratory confirmed CRS. One of the conditions in group A, along with detection of rubella IgM antibody or sustained detectable IgG antibody at 2 time points, 1 month apart, in the absence of a history of administration of rubella vaccine. What is congenital rubella infection? That infant has a positive rubella IgM test, but there's an absence of clinical signs from group A. What are the discarded cases? Negative serological result for rubella, irrespective of the clinical signs. So what were the results that we obtained? The average age of the CRS infants was 3 months, and the average age of their mothers was 25 plus minus 4 years. Out of the total infants, 88% were alive and around 5% were lost to follow-up. And in our cohort, with laboratory confirmed CRS, congenital heart anomalies and eye anomalies were most commonly detected. This was the forest plot depicting the odds ratio with 95% confidence interval of the developed multivariate binomial logistic regression model. And the final model, it showed that the odds of having cataract, retinopathy, glaucoma, microcornea, and age of the infant at presentation were 3, 4.9, 2.7, 1.1 respectively for the at-risk infant as compared to the not at-risk infant. So this was the nomogram which was developed, and the bootstrapping for calibration of the model showed satisfactory results, and this nomogram along with a web version is available on shinyapps.io, Rubella Eye. And according to this prediction model, let us take an example of a 6-month-old infant with cataract and retinopathy suggestive of glaucoma infection. The cataract, according to this table which is shown, according to this nomogram which is shown, would get a score of 35. You can see that the cataract gets a score of 35 on the top line. And the retinopathy would get a score of 50. So adding it, it will become 85. And if we see on the bottommost line, that is a prediction of having rubella, the last line if you see. So that 85 corresponds to around 0.68. So the developed model had an area under the curve of 0.68, which would predict the probability of having rubella of more than 60%. That is around 68%. So this was a very important nomogram which can be kept by the ASHA workers in primary and secondary health centers, and they can just use this nomogram and just see that what is the probability of that child having rubella, and then they can send those children to the tertiary care centers. So development of web server helps in the diagnostic external validation of the model, and this will also help in the external validation of the model by pediatricians, ophthalmologists, ophthalmic assistants, and ophthalmic technicians. It could help policymakers in taking a decision. This web server could be used in the far-flung rural areas where sophisticated high-end equipment is unavailable, and to the best of our knowledge, no such nomogram has been designed till date. So to conclude, we created a prognostic and predictive nomogram with various ophthalmological clinical characteristics of a child with suspected congenital rubella. If the probability of rubella diagnosis could be quantified with ophthalmological examination, it would give more care to those infants with a higher risk, which will subsequently help in the follow-up visits also. The developed nomogram would have a community-based utilization and will help in prioritizing attention to high-risk children and thereby avoiding loss to follower. Thank you so much.
Thank you very much, Dr. Parul. How you are actually taking this nomogram in your practice?
So we are planning to do an external validation of this nomogram in the primary and the secondary health centers and develop a external model. So we are going to, this was done as an internal model of the 5 centers that we included. Now we'll actually go into the community and see if the accredited social health workers, the ASHA workers, are able to pinpoint the children with suspected rubella and refer to the tertiary care center. So we are going to externally validate this nomogram.
Okay, so they are going to the places and getting the data.
Yes, sir. If any child comes to them, they will just fill this, they will just see
form,
what
yeah.
is the probability of
Yeah.
having, and if it is like, it has 68% validity. So if they feel that it is following in that category, like a person who a child who has cataract as well as a child who has retinopathy.
Yeah, yeah.
So the score will be higher. And if the child has 3 characteristics, cataract, retinopathy, and microcornea, so it will make
They
it
still
more
go higher.
probable
Yeah, that's
of the
right.
child having rubella. So they will not need a sophisticated slit lamp there or a ophthalmologist there. Just the ASHA worker can also do this.
So they can do this. Okay,
Yes, sir.
that's great. Yeah.
Yes, sir.
Right. Thank you very much. Thank you. So we have the last talk by Dr. Ankush Mahajan. Dr. Ankush is going to talk on OmniFlow, the drainage device, a perfect solution in the challenging glaucoma cases. And you're taking in consideration of your cases, those who are coming to the hospital? They are also included in the study or
Yes, sir. They are all included in the study, and the project is still going on.
going on? Okay,
Yes, sir.
okay. So do you find any difference in their detection and your detection at the clinic?
So at the primary health centers, we are yet to start, but this is going on at 5 centers in India.
5 centers in India.
Yes, sir. So they are
Centers means
collecting
it's a big
5
centers? or
big
like-
centers like AIMS and
Okay,
JIPMER
okay.
and
Right,
all
right,
those
right.
big centers. So they are collecting their data, and we devised this model based on the ophthalmology findings of all the 5 centers.
All
So
right.
they have cardiology findings also, so there is a separate team for that. They have ENT findings also, so they have a separate team for that. But for the eye thing, we have developed this
So these
nomogram.
ASHA worker, you're training them first or like?
So we are going to do, when we do
You
go
are,
out in the
you are going to
community.
start that
Yes,
now?
sir.
Okay,
Yes,
right.
sir.
Thank you.
Okay. Good evening. So I'll be talking about OmniFlow drainage device. So first, this is different from the tubes which we have known till date. There's no plate in the tube. It's just a 45 millimeter long platinum cured Loxacian tube which can be used for glaucoma drainage. Outer diameter is 600 microns, inner diameter is 300 microns. It has a Teflon valve which is built inside the tube. The valve, I think, has a pressure function. It opens up at anything above 10, but below 10 it keeps, it's closed. So hypotony is, I've not seen any hypotony when the valve is functioning well. The internal diameter of the valve is 100 microns and it gets expanded to 150 microns in case of high pressures. So I'll be discussing a few cases. So this was a 65-year-old female, post-keratoplasty glaucoma. Pre-op IP was 34 on 4 drugs. So the surgery was done and day 1 post-op was 10. 4 months post-op, patient was on 17 on 1 anti-glaucoma medication. I'll show the surgery of one case in brief. And the rest of the surgery is almost same for every case. So this tube has to be implanted, the valve part has to be implanted in the retroorbital space. This is something which was a brainchild of Dr. Kakadia. I had never thought of directing the aqueous from the anterior chamber to retroorbital space. But to think about it, it makes more sense. You don't get fibrosis as you get in subconjunctival space. There's a bigger space to accommodate that aqueous, provided the egress of the fluid can be regulated and hypotony is not created. So the valve functions very well, and it's very easy to place also. You just have to dissect and then use as you would do for a trabeculectomy, but then dissection is carried more posteriorly using a simple vectis. And you push the vectors down as much as you can till you can feel that it's actually in the retroorbital space. And then the tube doesn't need to be sutured. All you need to do is trim the tube to size, make a small scleral pocket, and this scleral pocket will hold the tube in place and not allow it to move. Not able to forward it anyways. So the tube is passed through the scleral pocket, then into the anterior chamber. I'm not a very tube guy. In fact, I've been doing glaucoma surgery since last 10 years now, but I had not implanted one single tube in last 10 years. The first tube I implanted was this one, and since then I've not been looking back. In fact, I'm implanting them more frequently because the results are very good. But one thing I'm very scared of, because I do cornea practice also. So I'm very scared of damaging the endothelium, so I try as much as possible to put it in the sulcus. So here what I'm doing is using a 21 gauge needle, and the needle is passed from the opposite end and the tube is fed into the needle as a guide path, and then you can feed it inside so that it doesn't go above the iris, goes below the iris. So this is another case. This was a 33-year-old male patient, had juvenile open-angle glaucoma in both eyes. I did MIGS on one eye because damage was not much. This was a more severe eye, CD1. 5 drugs since last 13 years. IOP was 20, temporal island on 10-2 fields. So this is a difficult case in any scenario for any kind of surgery. So, but with this tube, the 1 month post-op IOP was 12 on 2 AGM. I could bring down the anti-glaucoma medication from 5 to 2. And even after 1 year, the patient is still on 2 AGM and IOP is consistently at 12. So this is the surgery for that case. So I'll try not to repeat the stuff. The thing is, almost all the steps are the same, but this was a phakic case. So the tube was implanted in the anterior chamber. And one small thing which I am actually doing with these tubes is that, like I said, I'm a little more scared about the tubes touching the cornea. So I'm like cutting the front half of the tube by 50% thickness using the MVR blade only, so that the part of the tube which is there in the anterior chamber near to the cornea doesn't have a roof, has a floor, but doesn't have a roof. This case 3 was a neovascular glaucoma, has had previous vitreoretinal surgery with for a tractional retinal detachment. Now it developed neovascular glaucoma, was on maximal medical therapy. IOP was 44. We did a cyclocryo twice for this case, was not working. So I decided, okay, let's go for the tube only. And again, 6 months post-op, patient had IOP of 13, no anti-glaucoma medication, which was very surprising to me and for my colleagues, but this is the kind of results this tube has been giving. In this case, I did a combined surgery and we placed the tube in the sulcus. So again, using the 21 gauge needle to help guide the tube into the sulcus. So these are all difficult glaucoma cases in any scenario. Whenever we get a patient like this, we have to think 10 times whether you should do a trabeculectomy, whether you should do cyclocryo, whether you should do a destructive procedure. But having this tube in as a surgical armamentarium has made my life at least a lot more easier. And there's no subconjunctival flow, there's no bleb, so it's very simple to manage these cases. So case 4, this was an open angle glaucoma. I had a little difficulty with placement of these tubes, probably because of my technique, not a fault of the tube. But I think that the retrobulbar placement, retroorbital placement can be variable sometimes. Sometimes the tissues can be slightly thicker in the posterior part, sometimes you're not able to dissect properly, and it's more of a blind dissection. So when you go back, the tube can kink on itself. So I was getting pressures which were different. Some patients were getting a huge drop in IOP, some patients were getting not that good a drop in IOP. So I was thinking that there's something which we need to standardize the placement of the tube in the retroorbital area or standardize the placement of the tube in some other space. And the tube is very novel. There's a valve inside the tube. There's no plate. So I thought, why not just put it in the supraciliary space and let's see how it goes. So, so what I did was very simple. Been doing deep sclerectomies since long. So I did a double dissection, dissected down up to the deep layers of the sclera. Then used a crescent knife. This is not actually my idea. I later on researched, and there is Dr. Daniel LaRoche, I think, who had been placing tubes with plates into the ciliary space. So it's very simple. Dissect to the choroid, use a hook to simply create a pocket. Then again, for the sulcus placement, I used the 21 gauge needle. The tube was fed into the needle. The target was to keep 4 mm of the tube inside the anterior chamber behind the iris and 4 mm of the tube in the supraciliary space. Not more than that, because my retina colleagues were really scared in this case. In fact, one of them was standing by, and as soon as I finished my surgery, we did a indirect to check whether anything wrong has happened or anything wrong can happen. Now, this case now has completed more than 6 weeks. So till now, I've not seen any choroidal detachment. In fact, patient is very happy. I am very happy. No part of the tube is exposed anywhere. And one reason for no choroidal detachment probably, I think, is the valve. It is functioning so well, doesn't allow much egress of the fluid into the suprachoroidal space. So, but then I would probably like to watch this case for at least 1 to 2 years to comment further. But this case has been throwing out very good data. The IOP decreased after at 6 weeks. Patient is 14 IOP, starting from 16 IOP on 5 medications, now no medication. So the results, I've done 7 or 8 cases, 7 cases till now. The results I've got, in the types of cases I did was 2 NVGs, 2 open angle, 1 angle closure, 1 juvenile, and 1 post PKP. 3 combines, 3 tubes in the retroorbital space, and 1 suprachoroidal placement. The important thing is that 4 were placed in the anterior chamber, 2 were retroiris, and 1 suprachoroidal. And pre-op IOP decreased from 28.57 to 13.8 even after 1 year. It is very consistent. So it's more than 50% drop of IOP after 1 year. Medication use also decreased by 50%, which is very, very magnificent, I would say, at least in hands of somebody who's not put a tube in last 7 or 8 years. I had one key complication. The valve needs to be checked in every tube. So this tube had a faulty valve. I didn't check and put it inside. Later on when I took it, the patient had choroidals. Later on when I went in and explored and checked the valve, it was free flowing, was not functioning. So I had to change the tube and everything went well. One case of bullous keratopathy I did get, but again my fault. Novice surgeon placed the tube too anteriorly. Cornea went bad. So to conclude, this is a very promising technology, has a lot of indications and various ways in which you can use it. Reliable till date. I would say sulcus placement is much more desirable with this. And retroorbital placement has some positioning issues, like I said, and no complications like conjunctival erosion has been seen by me till date. Thank you.
Could you show the tube exactly?
So the tube?
Yeah. No, here, because I've not seen, because the surgical steps only, because separately, can you show the tube?
So
where is the valve and where exactly which position the valve is there?
Yes.
He has got in his presentation.
I think sir has that.
Where, it's at the middle point of the tube?
It's at the posterior end of the tube.
At the last?
Yes, sir.
The valve is there?
Yes, sir.
Not when it was the
No,
anterior?
No, the valve is in the end.
Okay.
If the? Yeah, that's what I said. When you're putting it retroorbital, it's more of a blind placement because you cannot see exactly what is happening to the tube when you're going so deep back. So I was discussing with sir for some sort of instrument which can be used as a guide, like the needle I was using. Maybe you can have some guide through which you can put the tube inside so that it doesn't kink, and then you can take the guide out.
Then you take it out.
So can I
45 mm length.
Ankush, can I clarify a little on your behalf? So the tube actually is tough enough not to be kinked. So even if it gets kinked, its own uncoiling force is more than the conjunctiva or tenon or subtenon tissue. So it will never remain kinked. Plus the movement of the eyeball will give it a way to unkink before it gets fibrosed. That is number one. And number two is that the recommendation of ours is to use axial length as a guide. So 1.5 times the axial length. If you cut the tube is available as 45 millimeters. So axial length plus 5 or 6 millimeters extra length is enough to reach behind the equator where the no fibrosis zone begins. So if we keep the tube very long in a small eyeball, then only there is a chance of getting it folded, not kinked. It might take a tortuous shape, but it will never kink.
It's a silicone tube, no? Basically, silicone tubes, they don't easily...
It's a silicone plus collagen.
Yeah,
Synthetic collagen and silicone mixed together.
Yeah.
So it will not erode through conjunctiva. It's very biocompatible. And the outer surface of the tube has microporosity. It's treated with platinum chloride. So it develops 400 microns microporosity. So it actually gets anchored. So even without suture, it will remain as it is. And you cannot remove it unless you really forcefully want to remove it. So it's not only biocompatible, it is biointegrable. So we don't need to put scleral patch, we don't need to put corneal patch or pericardium or any kind of patch.
One of my patients...
And the latest use of the same tube in a smaller version, not 45 millimeters, but 15 millimeters version, we shunt the fluid from aqueous humor to the suprachoroidal space. And in my opinion, that's working even better than the retrobulbar shunting. So probably in another year's time, we'll shift completely from retrobulbar space to the suprachoroidal space.
One of my patients, we had treated with neovascular glaucoma, and in about 10 days' time, the neovascular almost disappeared after doing this. We don't know that. Probably the toxins which were there, they got released into the retrobulbar space. I think this is going to be a great device for untractable glaucoma, at least at the present time.
True. Nice, and thank you very much. Thank you all, and thank you all the speakers, and wonderful session we had, and thank you audience for staying with us towards the end of this day and end of this session. Thank you very much. Thank you.